Hi, in this video, we will walk through a 10-minute moment on evaluation of a patient with a heart murmur. 10-minute moments were created to facilitate teaching at the bedside in the context of daily clinical work. Specifically, they help provide structure for direct observation and feedback on focused physical exam skills. Key teaching points are highlighted for just-in-time faculty development. This is a tool for formative assessment of physical exam skills, and it does not address history-taking skills. So let's get started. This patient has been told in the past there was a murmur on the heart exam. The task for your learner would be to perform a cardiac exam and evaluate whether the murmur is likely to be caused by structural heart disease. The initial step is to observe the patient and notice vital signs. Your learner should notice the patient's general appearance, comfort level, and mental status. They should comment on the level of effort with walking, breathing, and moving around in the examination room. They should notice if the extremities appear warm and well perfused. So, hello, Mrs. Jones.
Hello.
Now we're ready for the physical exam portion of your visit today. So I'd like to have us start by please stand up and then walk around through the examination room, coming around the side here. And in a clinic, you could have the patient walk down the hallway, and you may turn around and come back to your seat on the exam table. Great, you can have a seat again. How is your breathing right now?
It's fine.
Good. Now I'll check the circulation in your hands. Your fingers are nice and warm. Your pulses are strong. Very good. We're moving now to inspection of the neck veins. The right side of the neck should be examined if possible, since the normal aorta can compress vessels traveling from the left side, which can result in overestimating central venous pressure. Normally, we start with the head of the bed at about 30 degrees, and here we'll approximate that by using extra pillows. The first step is to distinguish carotid movements from venous movements, and we'll also have you position your head a little bit to one side. Once we see what probably is a carotid movement, we can palpate, and this helps us be more certain. Then venous movements are more complex, and the height of the venous column changes with respirations and increases with maneuvers that increase venous return. So pressure can be applied to the abdomen briefly to determine if movements rise and are likely to be venous. Now we will move to palpation of the chest wall to examine the apical impulse. We'll have the patient in the supine position for this, and we'll start by focusing at the fifth intercostal space in the midclavicular line. Avoid applying too much pressure, which could interfere with detecting subtle cardiac motion. We're looking for any abnormality, such as sustained impulse or lateral displacement or enlargement of the PMI. Now we'll move on to cardiac auscultation. And it is essential to start by establishing the heart rate and rhythm first. If a patient had significant tachycardia, bradycardia, or a newly irregular rhythm, this would be more important clinically than identifying a murmur. And before listening for murmurs, S1 must be distinguished from S2 in order to recognize systole and diastole. When the heart rate is 100 or greater, it can be challenging to distinguish S1 and S2 on the basis of timing alone. There are a few strategies to keep in mind. The clinician can palpate the carotid pulse while listening to heart sounds, noting that the carotid upstroke will occur between S1 and S2. Another strategy is to listen to S2 at the left upper sternal border, where S2 tends to be the loudest. Moving the stethoscope gradually away from this area, the S2 component becomes quieter. So, once systole and diastole have been identified, the learner can move to the next steps in auscultation. There are multiple ways to sequence an approach here, but the key points are to progress in a logical pattern, moving from base to apex or from apex to base, and to focus attention on one thing at a time. So the learner should listen to systole in each location. At the right upper sternal border, the left upper sternal border, then moving along the sternal border, reaching the left lower sternal border, and then the apex, and usually moving on towards the axilla. So, if a murmur is heard, the learner should be deliberate about noticing key features of the sound. Where is the sound the loudest? Does it radiate? What's the timing during systole? Is it early, mid, or late systolic? Is it pansystolic? What's the pattern of intensity of the sound? In other words, is it crescendo, decrescendo, or a steady intensity throughout systole? And finally, sometimes you can recognize the quality of the sound. It could be harsh or blowing, for example. Finally, we will review patterns of finding associated with several common systolic murmurs. We'll start with aortic stenosis. This systolic murmur is loudest at the right upper sternal border and is often well heard at the apex also. This murmur is crescendo during systole and has a harsh quality. More severe aortic stenosis has a crescendo that peaks later in systole and can be associated with a weak delayed carotid upstroke. So you will listen to the heart sounds and palpate the carotid simultaneously to evaluate for pulsus parvus et tardus. Next, we'll examine for mitral regurgitation. This systolic murmur is loudest at the apex and radiates towards the axilla. It tends to be holosystolic with a blowing quality, and the holosystolic pattern usually obscures S2, making it not clearly heard. Tricuspid regurgitation is a systolic murmur that is loudest at the left lower sternal border, also has a holosystolic pattern, but S2 is heard clearly. It also has a blowing quality. In some cases, tricuspid regurgitation can be associated with very prominent V waves on neck examination, where the height of the venous column varies greatly with the cardiac cycle. This is because regurgitant blood flow is seen in neck veins during systole, followed by a dramatic fall in the venous column during diastole. Finally, we'll cover the functional murmur. This one is heard best along the left sternal border, but the intensity is grade 2 or less and becomes quieter when venous return is decreased, for example with standing or with the Valsalva maneuver. The timing of this murmur is brief and it's in early or mid systole. So we would listen along the left sternal border. With a functional murmur, other elements of the cardiovascular exam are normal, including the jugular venous pressure, apical impulse, and peripheral pulse exam. Once the clinician has examined for systolic murmurs, it's important to remember to listen for diastolic sounds. The most common causes of diastolic murmurs are aortic regurgitation and mitral stenosis, both of which tend to be quiet and more challenging to hear. Aortic regurgitation may be suspected if there is a wide pulse pressure, bounding pulses on peripheral pulse exam, or a history of aortic root or valve disease. So, to examine for aortic regurgitation, we ask our patient to sit up and to lean forward slightly. You can also ask your patient to hold their breath for a few seconds while listening in this position. You'll be listening to diastole along the left sternal border. If an early diastolic decrescendo blowing murmur is heard, this suggests aortic regurgitation. To evaluate for the murmur of mitral stenosis, we'll ask our patient to put her head back on the pillow once again. And we'll ask her to turn a little bit to the left side, moving into the left lateral decubitus position, about right there. And then we will be certain to use the bell of the stethoscope, and we'll place it lightly over the apex. If a low-frequency rumbling murmur in mid-diastole is heard, this suggests mitral stenosis. And finally, an important part of every assessment is to comment on the learner's attention to the patient's comfort and well-being. How did the learner make sure the patient was comfortable throughout the examination? And how did the learner communicate with the patient during the exam? This concludes the 10-minute moment exercise on evaluation of a heart murmur.